Who here has ever seen a patient with syncope? How many do you see a shift? You know, I now get about 5 or 6 or 7 a shift. They're usually above the age of 85. Just pretty much every patient I see is above the age of 85, and thank you so much. And syncope accounts for about 5% of all admissions to the hospital. The problem that we have with syncope is it's a symptom. It's not a condition. And so we have to then go around and find the causes of that syncope. And today I wanted to look at a little bit of the definition, because you need to know the definition of syncope to be able to diagnose it. I wanted to have a look at some of the high-risk criteria, and I want to look at what we call syncope plus. Do you have syncope plus a symptom? And I want to tell you to forget about the vasovagals. They'll be fine. Forget about the situationals. They'll be fine. Forget about the dying swans. They'll be fine. There's only 2 groups you need to worry about. And that really you can get syncope down to a single question. Is it cardiac or not? And then I'd add one more question. And if it's not cardiac, is it one of the other 5 things that's going to kill you? Is it a PE? Is it a subarachnoid hemorrhage? Is it a AAA? Is it a dissection? You know, they're the questions we have to ask. And so syncope plus becomes syncope plus shortness of breath, syncope plus palpitations, syncope plus chest pain. So that's the way we've got to start thinking about syncope. Before we start though, this is a ex-official for the Canadians here. Now one of these people in the back is going to faint. So quickly, who thinks A is going to pass out? Who thinks B is going to pass out? All right, C. Oh, too late. Now, I want you to look at what happens afterwards. Should we pick him up? What should we do? Look at this. Oh, no. Right. Should we pick him up? What should we do? Oh, damn it. Okay. All right, here it is. This is what it is. Look at that. We've got super technology, and a bottle weighing this bit of wire down has helped it. So here it goes. He passes out. I know. And now watch the group. The group around him can't work out what to do. And you'll find that that's exactly the way it is when somebody comes in. We didn't know quite what to do. Did he have a seizure? Yes. Okay, so be very careful. Syncope is a symptom. The definition of syncope. You've got to get this right. There is a sudden, brief loss of consciousness. It has to be brief, but it is a sudden loss of consciousness, and it's associated with loss of postural tone. So if the person is standing, they go to ground. Okay? And then, and this is probably the most important thing, it is associated with a spontaneous recovery back to baseline. Yeah? They lose consciousness, go to ground, or they drop, if they're standing, they drop, but they come back to their normal conscious state. Now, I'm almost scared of touching anything here, but let's see. I hope this video works. This is the definition of syncope. Spelling bee. I think I'm going to lose consciousness, and he loses postural tone. Now, does he get spontaneous recovery? Does he ever? Watch this. Come on, you've got to go. Right. Sudden loss of consciousness, loss of postural tone, spontaneous recovery back to what he was doing again. Okay, now, how long is that spontaneous? It takes about 30 seconds, okay, to a minute. If you're older, it might take a little bit longer. Once it passes 5 minutes, think of seizure. Don't think of syncope, because it's a potential postictal at that point. Okay, that's a really good demonstration of it. So these are all the causes of syncope. All right, so you get these reflexes, the vasovagal causes up here. There's a noxious stimulus. Somebody's telling you all about some terrible food they ate last night at some strange restaurant that they went to, and you're kind of feeling a bit woozy, or you're seeing blood for the first time if you watch people do this, or somebody's getting a cannula and the person in the room passes out, all that sort of stuff. Situational, crisis related. There's also the micturition, the defecation, the carotid receptor syncope. People shave themselves and pass out. They turn their head. They wear a too tight a collar and they pass out. All of these sorts of things. They're all the rubbish syncope. Because nothing bad's going to happen unless they fall and hurt themselves. Okay? And there is a subgroup where the literature shows that if you've had trauma related to your syncope, you actually do worse. Because it's probably not plain old syncope, it's something else. But that's a very small group, small number of studies in that. This is the stuff we have to worry about, the cardiac causes, the ischemia, the cardiomyopathy, the valve issues, the arrhythmias. So things like, have you got chest pain? Is this an ischemic episode, decreased perfusion, you pass out? So things that decrease your blood pressure. So what decreases your blood pressure? Aortic stenosis. Elderly patients on exertion with aortic stenosis get a Stokes-Adams episode. Those sorts of things is what you've got to start thinking about. And then the orthostatic hypertensions almost fall into this rubbish group, but they're one of the most common ones that we get because the elderly have got autonomic dysfunction and they can't constrict their distal vessels, plus they've just changed to a new medication. And what does a new medication do? It lowers their blood pressure. Hello, right? And they've come in passed out. And then there's this danger group, which is the AAA dissection, subarachnoids, the PE and others. So we can divide it into these two groups. And I try and find, is there a potential cardiac cause or is this syncope in something else? And if I can work that out, then I feel pretty good. If I miss a couple of these, it's not too bad, okay? But if I miss one of these, it's potentially disastrous for that patient. Not for me, for that patient. So looking at it, we can sort of look at splitting it up into neurovascular bleeding or cardiovascular system in that danger subgroup. So TIAs, can TIAs cause a loss of consciousness? No. In order for you to lose consciousness, you've got to block out both of your hemispheres or kill your reticular activating system. A TIA doesn't do that. A posterior circulation TIA can cause loss of consciousness, but all the studies have shown that these people will have remnant neurology when they wake up. Okay? They will have ataxia, they will have vertigo, they will have symptomatology. Strokes can, big bleed, but that's related to bleeds. Subarachnoids are related to bleeds, and we know that bleeds anywhere in the body can cause a syncopal episode, and it's related to autonomic nervous system function. So a bleed in the gut, even though you don't have anything PR, can cause syncope. And that's why those studies looked at hematocrits and hemoglobins as being very important when they started coming up with San Francisco syncope rules and everything else. We'll talk about that high-risk criteria. How about seizures? Okay, so this is a group of patients in Germany that were having vasovagal episodes, okay? And to a bystander that watches this, and this guy, they ask him to count, and within, right now he starts to count. That's less than 10 seconds. But to a bystander, those arm movements, etc., look like a seizure. So the history, when you're getting the history, you need to understand what the difference is. So that looks like a seizure to somebody. They're those myoclonic jerks that are associated with not perfusing the brain. But they can be misleading. And the movements go on, and there can be very strange movements too. People can sit up, can reach. Now that looks like a full-on seizure. Even if I saw it in the street, I might call that a seizure. But it's got to do with their recovery. These guys all recover in about 10 seconds or so. All right? Okay, so this is really important when you're getting a collateral history that you understand what they're doing, and the most important question you're going to ask is, how soon did they take to come back? And this is a real seizure starting to happen now. So he feels he's getting the aura. They know it's about to happen. So the automatic movements start there, and it's sustained, and there's a postictal component when this man ends his seizure. It's a very, very different thing. But when you're getting into collateral history, you've got to be able to get this out of the people there, all right? You've got to understand what it's all about. There were some studies done that tried to look at, can we work out whether, on symptomatology, whether it's been a syncopal episode or a seizure. And these three things came out of a tongue biting. Now, tongue biting, lateral part of the tongue. You can get tongue biting in syncope, and it's usually the tip of the tongue, okay? So this is lateral tongue biting, incontinence, and a postictal component, okay? So those seem to be the three things that were most important. And the last paper on this was, I think, in 2015. They seem to be the most important things for differentiating between a simple syncope and a seizure episode, okay? Now, if you start getting other things like neurology in there as well, it might be a confounder, but you can get a Todd's paresis post a seizure, you can get a full hemiplegia. You've got to start thinking of that, and they're the things that make it complicated. Now, we don't have to sort everything out in the emergency department, you know. And if you don't get that it's a Todd's paresis, it doesn't matter. What you've got to do is the right thing. And as somebody said yesterday, no matter what you do in the emergency department, it's always going to be wrong, okay? Because, you know, with the hindsight, and a cardiologist will come to me and say, look, you missed that acute coronary syndrome, Pete. You missed it. And I said, right, I didn't have 10 troponins and 25 serial ECGs. You did in a cardiac care unit, right? I saw them for a few hours and we moved them. That's what's important. It's important to understand who you can send home and who you can't. Any neurology, you're not going to send them home, right? Bleeding includes ectopics, so usually will be associated with abdo pain, but doesn't have to be. AAA, do they get abdominal pain? Yeah. Do they get flank pain? Yeah. Usually older. So the story I share on this is I was working in a small private emergency department that I was actually running at the time. And an 82-year-old Chinese gentleman came in. He was out to lunch with his family. He got a little bit of, so he felt a bit strange, and then he kind of had a pre-syncopal episode. And I lump pre-syncope in with syncope, not to miss anybody. So if you felt like you were going to pass out, fine. So they lowered him to the ground, called the ambulance. He was a little hypotensive. They gave him some fluid. They gave him a challenge of 100 mil or something, 200 mil, and his blood pressure came up to 110 and he was great. Brought him into the emergency department anyway. I was on the shift. I examined him. I examined his belly. It was soft. I couldn't find a pulse. So this was in the days before we were using ultrasound. No pulsatile mass, nothing else to find. Pristine ECG. Everything was fine. Okay. Hemoglobin was great. No problem. What's the kicker with hemoglobin? Hemoglobin takes up to about 24 hours to show a drop in hemoglobin, right? So if somebody's had a bit of a bleed, that hemoglobin's going to stay exactly the same until you start changing other things, until it goes out somewhere. So it's out of the blood, you start diluting it, then you're going to find a decrease in hemoglobin, or you're going to get a decrease in your hematocrit. But hemoglobin itself will take up to about 24 hours to show in the blood results. But I said, look, you know, he's 82, he had this, after a while, it just doesn't smell right. I said, I just want to admit this guy. So I called the consultant that was on. He said, no, look, there's nothing to admit him for, send him home. I said, sure, but I don't want to. So I'll put him in my short stay unit and I'll look after him, or I can give him to you, you know, super duper, you know, incredible specialist that you are. We all fall to your feet and you can look after him, and it helps pay your kids' school fees as well. And he said, oh, sure, admit him. So admitted this guy, and at 3 o'clock in the morning he burst his AAA. And they came in to operate on, and he wasn't salvageable, right? And I got called up as the director of the emergency department. You missed the AAA, Pete. And I went, damn it. He had no pain, he had nothing. Emergency department stuffed up again. And then they read the notes, and the physician had actually gone in, examined him, abno soft, no pulsatile mass, no cause to find, observe overnight, discharge in AM. And they went, oh, the physician examined him. There's nothing there. It was all right. Right? That's what you get. But you know, you could miss them. So in the elderly, beware. They had a little bit of flank pain, a little bit of abdo pain, whatever. This guy had nothing, but just didn't look right to me. You can watch them for a little while. It doesn't hurt. 5. GI bleed. You can get a GI bleed. Oh, it's going to go over 5, mate. GI bleed. You can get a bleed from an ulcer. You don't have any blood, rectal blood, and you can pass out. Okay. So cardiovascular, some sudden collapse from an arrhythmia. That's what we've all learned. But all the studies are starting to show that it can take up to about 40, 45 seconds for you to lose consciousness. You feel a bit woozy, almost get a bit of pre-syncope, and then you pass out. Because as the arrhythmia starts, your blood pressure drops. Okay? So it's not always sudden, so beware. So how important are the cardiac causes? In all the studies shown, the cardiac causes showed a significant level of mortality in all comers. So if you had a cardiac cause of syncope, it was an independent predictor for overall mortality. You know, when they studied this group in the Japanese people that had a very low level of cardiac disease, those that had a cause, a syncopal cause that was cardiac, independent predictor for significant mortality. So this is a really important thing, cardiac syncope, and we've got to look for it. And then there's the syncope plus that I tell you about. So syncope plus shortness of breath or palpitation or chest pain or headache, anything like that, and you've got to start thinking of those deadly causes. So history, examination, investigation, does it give us anything? I'm going to go for about another 10, is that all right? Will that be all right with you guys? Yeah. Does it help? I'm going to be going for another 10. Okay, so in looking at the literature, let's look for the high risk features in patients. So, I'm sorry this slide isn't great, but anybody that had an abnormal ECG, what's an abnormal ECG? Anything that's not normal. Okay? Anything. Abnormal ECG. Particularly ventricular arrhythmias in the past. Duh. You've come in with syncope and you've had a history of VT, I'm going to say you'll be fine, go home. Of course not. History of congestive cardiac failure comes up quite a bit. Okay? And in fact, in one study, doing a beta-natriuretic peptide was shown to be an independent predictor of something bad's going to happen to you. Looking at a few others again, abnormal ECG, age greater than 65. In fact, in medicine, as a general rule, age greater than 65 is something bad happening to you. Age greater than 45 in cardiology means something bad's going to happen to you. Who's starting to feel not that good today? All right, so cardiovascular disease, syncope without prodromes, and abnormal ECG. And these are all the trials that that tried to look at 1 year mortality, risk of arrhythmias. So all of these trials have tried to risk stratify patients. And this was the beginning of the San Francisco syncope rule, where they thought abnormal ECG, a shortness of breath, a low systolic blood pressure, hematocrit of less than 30. So hematocrit of about 30%, hematocrit is a calculated figure. Hematocrit of about 30% equals about a hemoglobin of 10. And every 3% that you drop your hematocrit means you've lost a unit of blood. Okay? So if you start getting a hematocrit of 27%, it means your hemoglobin's down to 9. Okay, and that's a good way to use hematocrit to work out whether these patients are losing blood or not. And congestive cardiac failure. And this was a great rule. The problem is 98% sensitive. It says something bad will happen to you. I just don't know what it is. Okay? And the way to apply this rule is not when a patient comes in, but to apply it at the end. When you're about to send a patient home, say, hang on a minute, let me just have a little think of the rule. Has this guy got a hemoglobin of 9 and I'm going to send him home? Something bad's going to happen. Okay, that's how you apply these rules at the end. And there's tons of these rules. That's a beta-natriuretic. The Rose score used the BNP levels. So these are the high risk criteria. Older patients, greater than 65 usually, any sort of cardiac history, but especially congestive cardiac failure, and an abnormal ECG, anything other than normal. You want to find out what they're doing at this time of the syncopal episode. Were they exposed to a noxious stimulus? Okay, what were they actually doing at the time? I was just sitting down, talking to somebody across the table, and I passed out. So I had one of these guys recently. I was sitting there reading the paper and I passed out. The resident gave me the story. And I said, oh, that's pretty good. Can you tell me anything more? He said, oh yeah, he woke up, he was in AF, and he had this pain down his left arm. I said, oh, that's not good. I said, all right. So we went, So I go and examine the guy and I get a history, and I do this because I trust no one and I believe nothing until I've heard it myself. And all of my registrars use this now: trust no one, believe nothing until you've seen it yourself. And I go and examine the guy and I said, "Oh, so what were you doing?" He said, "I was reading the paper." I said, "What were you thinking about?" He said, "Oh, I was thinking about the CT scan that I just got this morning, because they removed a little cancer from my neck and they were doing the CT scan to see if there was any spread of cancer. And I couldn't understand the reports. I was, really stressing out about it." I said, "Anything else?" He said, "Well, my brother died about 3 months ago from cancer. And so I thought I might have it too, and I haven't got long to go." And I started to sweat up a little bit and I was feeling really bad. And then I woke up. I said, "Oh, has that ever happened to you before?" "Yeah, it happens a lot. I faint a lot." "And you've been worked up?" "Yeah, worked up extensively." "And how about this atrial fibrillation?" "I've been in that for years and my doctor looks after me. And this arm pain, I always wake up with this arm pain. I sometimes get a vice-like headache as well. Happened to me every time." I observed him for a while and I sent him home. I mean, this is something that recurs. It's happened before. It's been fully investigated, right? You've got to get the history. The history is really important. Little old lady that walks out of a house, comes in. I've had a syncopal episode. I went out for a walk to get a little bit of tonic water, and I passed out outside. And I got this pain in the back, in the middle of my back, dissecting thoracic aneurysm. I said, "Oh, let's hear a bit more of the history." "So why do you need tonic water?" "Well, I usually mix it with my gin. It's a hot day, and it was a very hot day, and I went outside and I thought, I'm going to have a bit of gin today, so I'm going to have some tonic water." Walked out, the heat hit me. It was terrible, and I started to panic. I have panic attacks, So I had a panic attack, and I thought about all these things that had happened. My son was viciously stabbed by his girlfriend approximately 6 months ago, and since then I can't sleep at night and I have panic attacks, and I thought I was going to pass out, and I did. So what about this back pain? I've had that for years. The history is really important, okay? And you can get a very subtle part of the history that changes everything. Vitals, what are they? Have they done tongue biting? Incontinence? Listen for murmurs. AS, mitral incompetence. Have they got a neurodeficit, and is there anything in their belly? And pop the finger up into the rectum. Okay, have they got any blood? ECG, about 5% yield. No evidence that any other investigation makes any difference. When you get a positive ECG, it's good. When you get a negative ECG, it's also good. Less chance of an arrhythmia. And I'm sorry, guys, I'm going over, but I'm going to go through a couple of ECGs. Hemoglobin, hematocrit, pregnancy and ECG are the investigations I always must do. If you're a childbearing Asian woman, I want you to have a pregnancy test, because there is a higher incidence of syncopal episodes in pregnancy. And this is my ECG criteria. I must look at every ECG, and this is my formula: A squared, B squared, C, WPE and long QT. And if you cover all of these, you've covered all the ECGs of syncope that mean anything. And you can rest assured that you've looked for all the bad things. So this is somebody that comes in with chest pain. Let's not labour the fact. There's ST elevation inferior leads. This is an ST elevation MI with reciprocal changes. This is acute coronary syndrome. This is the first A in A squared. This patient comes in. He's a 38-year-old Greek man who collapses during a soccer match, and he comes in, and this is his ECG afterwards. He's got these T-wave inversions here, and if you look carefully, he's got little Osborne-y kind of waves. They're called epsilon waves in this, and this is more of an epsilon wave. It's a specific finding and only occurs in 30% of the patients that have this condition. What's the condition? It's arrhythmogenic right ventricular dysplasia. It's an autosomal dominant disease, but it can have an autosomal recessive trait as well. It occurs in 1 in 5,000 of the population and is only second to Hockham as the killer of young people. This is a significant disease. They have a ventricular arrhythmia. When it stops, it's called syncope. When it continues, it's called arrest. Okay? And this is about, and mostly it occurs in Italian and Greek descent. And it's funny to say that, I shouldn't say this, but the recessive trait is called Naxos disease or something like this. And the trait is that men are hairy. And so it's in Greek and Italian men. I mean, well, what, of course they are. And their woolly hair is what they're described as having. All right? but it's a recessive trait. 1 in 5,000. That's the second A that we see in A squared. What's B? 39-year-old syncopal episode, has a history of his father dying suddenly. That's the ECG, and we'll call this Brugada syndrome. Everybody heard of Brugadas? You will this afternoon if you haven't. This downsloping form here, it's a sodium channelopathy of some sort, and you get this kind of slippery, slidey curve, and they get this polymorphic ventricular tachycardia. They need a pacemaker, okay? Brugada is one, and then all the other blocks. There's an old bloke that's had a faint, so what's he got? He's got a right bundle branch block, he's got a left axis, and he's got a first degree block. He's got a trifascicular block, and he needs to have a pacemaker. So that's the other B. All of this is in a massive blog on the website, you know, so you can go and have a look at all of these. What's this one here? 22-year-old man collapses during a basketball game. This is his ECG, and he says to me, mate, I've got to go home because my mother found out I had a collapse and she's coming into the hospital. I'm going to be in big trouble. And will I send him home? This guy's got Hockham. He's got left ventricular hypertrophy. He's got these dagger-like Q waves. These are not ischemic. They're not wide enough in the lateral and inferior leads. He's got Hockham. He needs an echo, this guy. So that's a C, the cardiomyopathy. The W is WPW, the slurred upstroke. The PE, all the ECGs of PE, which we'll go through later on, and then long QT. So this is a patient I had a little while ago, IV drug user on methadone. Look at the QT. Corrected QT is massive. And what happens to these guys? They start to do that. And then he did that. Okay? So A squared, B squared, C, W, PE, and long or short QT, right? Whatever you want it to be. And all of this is on a blog. So who to admit? The high-risk guys. Apply your syncope rules before you send them home. But remember, think of syncope as the cardiac and the syncope plus components. Thank you. Sorry for going over time.